Anil. We'll move on to the last talk for the session. I'd like to invite Dr. Raghav Bhatia to the stand. So he'll be speaking to us about what does the future hold for cardiac screening.
Good morning, everyone, and thank you very much to the conference organizers for the kind invitation to speak this morning. Over the course of the next 10 minutes or so, we will go through what does the future hold for cardiac screening. I have no conflicts of interest to declare. Just to set the scene, we know that every week in England and Wales, there are at least 12 young sudden cardiac deaths that occur. In up to 80% of these individuals, they have no pre-existing cardiac symptoms or pre-existing cardiac diagnoses. Such data really highlights the importance of early identification of conditions that are associated with sudden cardiac death. Now, cardiac screening really provides us with a window of opportunity to identify, intervene, and protect lives. As I'm sure many of you already know, that CRI provide screening to anyone in the general population on a voluntary basis between the ages of 14 to 35, and in elite sports, certainly, this is usually mandated by the sporting governing body. Our screening algorithm, as things presently stand, include a health questionnaire which is reviewed by a physician on site, and incorporated with that is the resting 12-lead ECG, and if required, a transthoracic echocardiogram. An individual will be provided with one of three outcomes, which may include being given the all clear and reassurance, perhaps being recommended to come back for a repeat ECG, particularly in the setting of a juvenile ECG pattern, or being referred to secondary care for further evaluation. Our data suggests that 1 in 300 are identified with a life-threatening condition. Now, there are some emerging concepts, much of what we already know from athletic populations and really are with one-off ECG evaluations perhaps, but there is some emerging concepts around serial evaluations. We can debate what does serial mean, annual or perhaps once in 2 years, 3 years perhaps, but the existing data relates to our colleagues from Italy who have demonstrated by evaluating a consecutive series of competitive athletes aged between 12 to 18 from the Veneto region over an 11-year period, that if they were evaluated with a clinical evaluation, an ECG, and some form of a stress test, the majority of these individuals were male, 96% were white, and the mean number of screens that these individuals had was 3.7 screens per athlete. The median age, importantly here, was 13 years. They have reported upon their experiences of evaluating 15,000 such athletes. 10% of the cohort underwent additional investigations, from which 0.4% were diagnosed with a cardiovascular disease that was associated with sudden cardiac death. If we look at the diagnostic yield with the single evaluation and compare that to the serial screen, we can see almost a threefold increment in the diagnostic yield with the serial evaluation in this adolescent cohort. Similarly, building on their previous experience, they have reported upon their outcome data from N equals in excess of 22,000. And interestingly, that in the number of individuals that were identified with cardiac conditions associated with sudden cardiac death was 0.3%. We can see, based on the bar graphs, that a repeat evaluation, as well as with an increment with advancing age, the diagnostic yield increases as well. But of course, I would like to emphasize that we need more data from other populations, including potentially different age groups. Now, there is an epidemiological paradox when we talk about prevention of sudden cardiac death. The bars on the left relate to the incidence rate of sudden cardiac arrest per year, and we can see that perhaps in individuals who've had a resuscitated sudden cardiac arrest, perhaps those individuals with a confirmed cardiomyopathy or an electrical abnormality, and even those with impaired left ventricular ejection fraction may be regarded as having a higher risk for sudden cardiac death. But if you look at the absolute numbers of sudden cardiac death, it is actually individuals in the general population that are actually perhaps most at risk. And this paradox really underscores the need to understand how we can prevent tragedies occurring in the general population, perhaps with scalable tools incorporated into that. And that's where I think we need to personalize how we prevent sudden cardiac death. Enter artificial intelligence. I think from the outset, I would like to emphasize that my personal stance on this is that it needs to be incorporated into routine physician led care. We can see that within AI, there is machine learning and there is also deeper learning, which uses deep neural networks to process complex and often quite non-linear data. This seminal piece of work by the group from Imperial College introduces the artificial intelligence risk estimation platform, which really uses AI to analyze ECGs and not only just predict risk, but also when a cardiovascular event may truly occur. They trained the model based on over 1 million ECGs from data from North America and used deep learning and discrete time survival modeling to predict the time to the event, not just the risk. Importantly, this data was validated across very diverse cohorts, not only in North America, but also Brazil, and data from the UK Biobank. Very nicely, they demonstrated that their model accurately predicts all case mortality as well as ventricular arrhythmias, and they were able to integrate this into certain biological pathways and supported their data with genome and phenome-wide association studies. This is a very interesting study from colleagues from North America where they utilized artificial intelligence to potentially predict the underlying mechanism for an individual having a sudden cardiac arrest, i.e., was it a PEA arrest or was it due to ventricular fibrillation? I would like to emphasize that there was no ECG data used here, there was no cardiac imaging data. They utilized demographics, information gleaned from the EMS consultations, symptoms perhaps an individual experienced prior to their cardiac arrest. And they were able to differentiate between these two very common modes of someone having a sudden cardiac arrest. Individuals who were younger, perhaps had cardiovascular symptoms or were diagnosed with a cardiomyopathy, tended to have ventricular fibrillation. Those that may have had certain comorbidities such as anemia, they may have a higher body mass index, perhaps be of an older age group, went on to have an arrest that was due to PEA. Now, such applications may show some potential to inform how we potentially target resuscitation strategies and overall improve our understanding around mechanisms that lead to cardiac arrests. This study is very interesting and it came out last month, using data from 8 months over the period, I think it was around 8 months in 2024. And it was led by colleagues at Cleveland Clinic, Ohio. And they looked at nearly 50,000 undifferentiated individuals who were evaluated at the Cleveland Clinic. Over 100,000 ECGs were utilized, and they fed that through a recently approved FDA HCM AI algorithm called VIS-HCM. And they used that to essentially flag up the ECGs that may be in keeping with a diagnosis of hypertrophic cardiomyopathy. The overall yield was just under 3%, and interestingly, 40% of those individuals already had a diagnosis of hypertrophic cardiomyopathy at the Cleveland Clinic. 54% had an alternative diagnosis, but 5% were diagnosed with hypertrophic cardiomyopathy for the first time, purely using the ECG and this AI algorithm. We can now see that using this within a relatively short space of time, with a very high volume of ECGs, how we can potentially identify individuals with HCM that may not have been given that diagnosis previously, and also importantly appraise their first-degree family members in a timely manner. Looking at the probability thresholds that they utilized, if that was at least 0.85 or above, that was associated with a higher probability of a diagnosis of HCM purely based on the ECG. Now, when we think about sudden cardiac death and the prevention of it, I would like to emphasize that that risk is quite dynamic, and that again is incorporated into how we screen, particularly moving along from perhaps a one-off screening evaluation, and also thinking about perhaps remote monitoring and how we might be able to assess someone's risk for sudden death more temporally. Now, there are some challenges to the widespread adoption for AI, and this includes, above all, us actually truly trying to understand the AI algorithm, the data that's going into it, the outcome data, and understanding how, well, firstly, how to interpret that data, how we can incorporate that into our existing workflows, but also thinking about some ethical constraints, particularly when you're dealing with such high volumes of data in terms of who is accountable if something goes wrong. Going back to cardiac screening, we've spoken about the ECG, we've spoken about different screening algorithms. That's very much around the screening day, but there are so many other cogs in the wheel. There are concepts that we need to not forget about, particularly the administrative, the logistical considerations before a screening, relevant to our own screening program with CRY, issues around fundraising. And thinking about all these different aspects around screenings, we perhaps can think about that these are very resource-heavy processes and how we need to incorporate AI at every step of the way and use modern technologies to essentially build sustainable networks and sustainable screening programs. And above all, I think we need to ensure that we have good engagement both with primary and secondary care stakeholders throughout this to overall reduce the heterogeneity in care that we sometimes see. In preparation of this talk, when I was thinking about cardiac screening, I would like to emphasize that cardiac screening is actually not just limited to screening in the sporting arena or perhaps in the general community. I've recently set up a dedicated ICC center up north, and screening is very much part of my day-to-day practice. When I see family members where perhaps there's been a sudden death, or perhaps individuals with a confirmed phenotype for an inherited condition, we screen their first-degree family members every day. And it's important to think about how we can ensure that we are offering this to everyone who require it, and to think about how to deliver this sustainably going forward. I think at the heart, we must ensure that education is a core principle to ensure that our workforce are trained and are well equipped to deal not only with the existing knowledge base, but to get to grips with the future, particularly with modern technologies. To conclude, I think cardiac screening continues to save lives, yet evolving data around this frequency of screening, equitable access, and sustaining the delivery highlight the need for ongoing refinement. Artificial intelligence is redefining how we interpret data and offers a plethora of opportunities. But I think we need significant ongoing research to truly understand how we can adapt these technologies to our current practice. And I would also like to emphasize, and something perhaps we haven't touched too much on, is that we need to think about places not only in England, but also more broadly, which may not have the resources that we have, and how we can essentially sustain equitable access of care within those populations. And of course, education and collaboration remain central to progress. Thank you for your attention.
Thank you, Raghav. I'd like to invite all the speakers up on stage, please, for our vibrant discussion and questions and answers from the audience.
I can pass the mic around if anyone.